Babar Rao. As many of you know, I'm a dermatologist in New York, New Jersey area. And I do a lot of other stuff like research and teaching in dermatology. And then we have Danish Bhatti is chair of our APPNA Merit, who basically has been leading these efforts this year and in previous years also with me and Shahid. Then we have Uzair, Syed Uzair, he's in Toronto. And if you want, he's like encyclopedia of any Pakistani doing any health related stuff anywhere in the world. So anything we need, we usually call him Uzair. Who is this guy or who is this person? How do we contact them? So Uzair knows a lot, he does a lot. And then I think Shahid is not here. Let me see who else is here. Yeah, Shahid is, I think, joining. Shahid Rafiq, he's a neurologist in Baltimore area, or in Maryland, sorry, and has been the first chair of APPNA Merit, and now he's helping Danish, and I'm helping all both of them in running these efforts. As a reminder, this is a CME, and it is like supported through APPNA. So we will follow all the rules and regulation in reference to that. Also, if anybody have questions, please write it in the chat box or question answer area mostly. And if your question is really hard, then raise your hand and we'll try to bring you in. With that, I'll just go to now Waqas Ahmed, who's a doctor in Jacksonville, Florida, obviously originally from Pakistan. And then other than being a nephrologist and a hypertension specialist, he really has expanded into a healthcare delivery in Pakistan and in United States. He's CEO of American TelePhysicians and Shifa for You. And in that, he's very, very well known in tele health in United States. And they also have now extensions in Pakistan. They're getting involved and are involved in healthcare help and delivery in Pakistan also. Also, he has been recognized by World Bank, and I've known and seen his video from he talking in United Nations as a guest speaker. So we will actually just let and I know him as a friend, as a person. He's a legit guy and a really, really nice, humble person. Met him many years ago. And since then, we've been friends at as a personal level and at professional level. So I'll let Waqas get started. And please tell us, Waqas, what you are doing inside the country, outside the country. And if people want to get involved in this effort with you, how can they get involved? And in the end, we'll then take some question and answers. So I'll turn it over to Waqas.
Assalamualaikum. Thank you so much, Dr. Babar. Very humbling experience. And I'm also very grateful to see Dr. Uzair. I must tell Dr. Uzair is actually one of the mentors, and he is the person who I actually met initially when I had this idea to start our Shifa for You project. And then thanks, Dr. Bhatti, to leading this there. You and I have spoken multiple times, I know, with this telemedicine and neurology. So what a great initiative APPNA is doing on this one. Assalamu alaikum, everyone who has joined us and in this session there. This talk actually is very close to my heart because I actually started my journey in telemedicine digital health from Pakistan. And I finished my nephrology training in US in 2012. I did my graduation from King Edward Medical College 2005, and I moved to US in 2007. I did happen to work in New Zealand for a year while I was waiting for my visa. And then, so that gave me exposure to multiple healthcare systems across the world. In Pakistan, I grew up in Kuwait. I've seen the healthcare system there. And then I obviously came to US and then, had challenges. We see challenges here. So it wasn't until 2015 or 16 when I started really thinking out of box. I was part of the group practice. And but started reading how different healthcare issues are impacting healthcare delivery, not here, but also in Pakistan. In 2013, I became part of US Educational Foundation and started going to Pakistan on frequent travels to give lectures in different medical colleges in Pakistan, hypertension. And that gave me, some obviously insight, how much need was there for second opinion services there. Not a new idea, it was, but obviously it was not done in a more kind of collaborative way. So we should have a second opinion service in Pakistan, utilizing US physicians giving not just kind of volunteer, but also kind of how can be this. There are a lot of physicians who want to go back to Pakistan, want to settle there, and they're looking to kind of start their practice there. So that was one idea which was kind of, struck me at that time. It wasn't until 2016 when, unfortunately, my mother, who has chronic liver disease, and I started facing a lot of problems where she would never get a blood work in time. She frequently ran out of medications, and and how hard it becomes when your parents are away and you want to get involved in their care. So I thought of really a platform where you can go online and order services for your parents in Pakistan. That would solve a lot of problems there. But at the same time, I thought like maybe utilizing the same platform, we should solve the telemedicine part, and also how can we involve local physician and the US-based physician. So that was kind of the idea which led me to start thinking about doing a project in Pakistan. I know this is a CME talk, so obviously I'm kind of giving this based kind of on a disclosure base too, because what I want to share today's talk is the practical experience, not just the education part, but actually practical experience, how we evolved, what are the challenges we face initially, what are the challenges we're still facing, and what's the roadmap, and of course, want to make it very collaborative, and would love to kind of, have discussion panels, because the whole idea is how can we make improve the healthcare infrastructure in Pakistan. So in 2016, I decided to, give up my very lucrative practice and start this startup in Pakistan with the help of my brothers in IT and with my other physician friends, co-founders, and we'll launch this project named Shifa for You in Pakistan. And ran it for 2 years, expanded it. I'll talk more later on. And what was the motive behind, of course, help my parents, but also how to kind of digitize the healthcare system in Pakistan. That led us to a lot of recognitions in the US, and I was very humble and honored to be recognized by various organizations, IFC, World Bank, and American Telemedicine Association. In 2019, was invited by United Nations to present the concept of the connected healthcare model. And then we brought this project in the US. So I'm very proud that we actually started our journey from Pakistan, and then we brought in the US. And alhamdulillah, we expanded very well in the US, because then COVID came in there. Obviously, telemedicine became pretty more boom. And now, inshallah, we are in a process of launching by end of this year in Australia also. And we already have some projects running in Africa as well there. So with that, I'll kind of go into kind of what was the kind of infrastructure and what as I said, it's a kind of CME talk also. So will try to kind of combine that also in that context. So purpose of this discussion will be to understand what are the current issues of healthcare delivery in Pakistan. We'll also learn about a connected digital healthcare model. I'll certainly give example of Shifa for You and some of the other healthcare startups in Pakistan, because that's the practical way forward. And then obviously we'll touch base how COVID-19 when they came in, and why this connected healthcare model became a lot of value and brought a lot of value for this COVID-19 was a new, what we call a new healthcare delivery era right now. And then I'm being honored and kind of to be now part of at the national level healthcare advisory board by the government of Pakistan. And I've shared some of the recommendations for the digital healthcare and telemedicine policy in Pakistan, which is kind of being at legislation level. So I'll share that also, what I have shared with the government of Pakistan as well. So if you look at currently, I see and we all know this, it's just kind of the three problems I'll categorize into: problems what we have with the patients in Pakistan, problems what we have with the physicians and work and the medical provider sides, and then what are the system problems there. If you look at the patient side, I believe the number one biggest problem in Pakistan is the education, the poor patient education. A lot of myths, lack of awareness. We don't seek medical advice until it's too late, and then we all know how we have worked in Pakistan, even those who are in the US, but they've seen how they go to one doctor to other doctor, and then unfortunately, it's just there's no preventive care. There is a relative shortage of primary and specialist physician in, when I say relative, it means they're in urban areas. I mean, there are a lot of physicians, especially the young physician, and with the help with this private medical colleges, without going into much kind of political debate. I don't think there's a true shortage. I think it's more relative shortage because especially for people living in smaller cities and villages, naturally, when you're a physician, you want to work with a bigger hospital, bigger lifestyle, better lifestyle there. So that's kind of one of the big issue there. And another big issue is there's no insurance system there. Most of the 85 to 90% population lives on a self-pay model. I know with the Sehat card that is changing, we will touch base on that, but that's one of the big problem. We certainly have issues at our doctors workforce. There is a lot of reason, the infrastructure, training infrastructure, the payment infrastructure for our doctors who get trained, and then we all are aware of those challenges. And there is certainly a big gap in our training system also. And then there are problems with the government system levels there's no policy for any digital healthcare. There's no policy for the hospitals having medical records. We all know there's you go to one doctor, you have a prescription, you go to the next doctor, he writes another prescription. No one bothers, honestly. Most of them do not bother to kind of to see what the previous medications are and interactions are there, because there's no once unified record system there. And then obviously the telemedicine service, which is we saw kind of up and rise during COVID there, but what is really kind of interesting, because most of people still think telemedicine in Pakistan is just the video or audio consultation. I know a lot of the programs were run there, but it's okay, they're using Skype or WhatsApp, the things. The video consultation is the telemedicine. So we'll touch base on that. That's not the kind of the reality is on that. If you look on the outpatient side world, one of the other big problem for the patients is that you have to go to each place to get the services there. And that is a universal problem even in the US and any other system there too, where you go to doctor, then he writes a prescription, the patient goes to the labs, they get the medications, and they get diagnostic services. In the US, at least, the issue that those orders come back to doctor's office and they call. In Pakistan, we obviously don't have that. It's a patient's responsibility to get the results back to the doctor, because there's no reporting back to doctors there. So if God forbid, I'm a nephrologist, if some patient has any high potassium or high creatinine, acute renal failure, unless the patient gets the lab work and then go there, there's obviously there's no. And that is where I think one of the big challenges we also as a physician living in the US, we see that we get a lot of time our relatives, they try to get a blood work done, they see some abnormal value, and they just text message and said, okay, well, can you help me? What does that mean is there? So a lot of time the patient journey starts from blood work. Someone will just say, okay, I will doing a lipid panel or something, and then they will find something abnormality in this there. So obviously this is a big problem there. I know the government, they try to implement this healthcare insurance card. They started with KPK, and then obviously they're now launching in Punjab there. Indeed a great program. I met with their national director when during my visits there, had a great discussion about the utilization. The very unfortunate reality is, which is due to our healthcare system, if you allow me to say about corruption, it is unfortunate there. Because it essentially allows patients to have a limit up to like 750,000 rupees, 7.5 lakh rupees per year. And when the patient goes to that, those hospitals which are enrolled, and they scan the card, they have a system, it tells them what's their limit is. And then if it's like pretty much like a blank credit card, they try to do as much, not every hospital I'm saying, but this is becoming a very more and more common problem. This was shared by me by the state life insurance chairman who are running this policy. And then they essentially a lot of time unnecessary testing is being done. And then by the time patients really need down the road that year, if they really need actual healthcare services, they do not have that balance left. And then since there are no healthcare record system in the hospitals, there's no true audit. What the audit is being done right now is a paper chart. They send these paper charts copies to the Sehat card for reimbursement, and we all know there's not much time to review all the paper charts and everything there. So that's definitely a big challenge. And this was a challenge which we have in the US government side too, when they started implementing, CMS started implementing in the US, the EMR system there. So what the kind of solution, what is we, utilizing the technology to kind of develop a system which can address all these parts. Obviously, no one organization can do that alone. Obviously, a lot of time it has to be a public partner, the public and government partnerships, because the government cannot do it alone. Private sectors needs help too. But reality is, if you look in this data there from, we have a huge youth population in Pakistan, and the utilization of technology is there, but it's obviously not very coordinated. No one imagined about 10 years ago, or like there would be an Uber in Pakistan, because how we did not have Google Maps and all those things, but now you can see every single person is using that smartphone also there. So healthcare got to be digitized, and it is not just a telemedicine, it's the entire ecosystem which needs to be built. And that's what I think the main focus of my talk going to be. What is that connected healthcare model, not just the audio and video and telemedicine part. So if you look at the problems, why? Because patients want, affordability, they want care at home. A lot of physicians who are working, they're very busy, but there are a lot of physicians who are young physicians who are not busy. They're looking for patients. They don't have patient load. On the other side, those who are super busy, they don't have time for months and months. There are a lot of women physicians at home who, after marriage, they due to logistics issues, they cannot work and they want to work from home. There are the healthcare facilities, obviously they want to decrease their costs and have more engagement. And now Sehat card insurance payment, or some of the private payers, they obviously want this more audit and kind of how they can be more involved, be more transparent. So this is what the connected healthcare models draft look like, where that a platform which can link patients and their family members with all the stakeholders. And who are the stakeholders? Doctors, hospitals, diagnostics centers, lab, radiology, and pharmacies, payers, insurance companies. So the idea is like how you can build one connected healthcare model, and that will do two things. One thing, which is going to be a future care at home, like an Amazon model, where if you are a patient at home, you want to see a doctor, if that medication condition can be dealt at home, see a doctor online, get your medication delivered at your doorsteps. If you need testing, get this testing there at home as well there. This is where, when we build this Shifa for You, that problem which I was facing with my mother, not being able to go frequently to these different lab centers and pharmacy and all things, there, get care at the home there. Phlebotomist comes home, get a blood sample, result comes online. That's one area. Obviously, there are some services which patients will need to go outside, procedures like specialized radiology, MRI, CAT scan. That also needs to be digitized so they can find easily, schedule services easily, and go there. And of course, hospital care, digitization hospital is an entire different spectrum. We all know like how the healthcare in the hospital is also fragmented. They're very much overloaded, work hard, but I think not in a smart way. Those are the operation and processes which needs to be implemented to make those processes very smooth there. So as I mentioned, this was the one model, where the world is going is the Amazon model, where they can find services online, get delivered, care at their home doorsteps. What it does is it does improve their health, decrease healthcare cost. It doesn't engage families, decrease hospitalization, and remote patient monitoring is becoming more and more kind of a backbone of these. But it does require data filtering. As a physician, you cannot see, review the data of the thousands of patients a day. It got to be filtered there. So obviously, there's a big role for technology is there. Another big challenge, which is very common in Pakistan, patient gets admitted to the hospital. They obviously go to the hospitals. When they get really sick, they get discharged. That follow care is very chaotic, and that's where it keeps things, it's just that thing happen. Same thing is honestly is in the US also, like there's a gaps in the follow-up, especially when the patient goes to nursing home. And this is where our company is focused on the US side for the nursing home, senior living cities in the US side too. And the essential, if we go one step further, this is the kind of future where every specialty has its own these needs and spectrum, and the physician's needs all different there. So I give example for like a diabetes. You want to see a diabetes doctor online there. They want patients' blood glucose monitoring. Some services are extremely easy to do for telemedicine. I mean, endocrinologist is one of them. All they need is a data of the blood glucose readings and the labs, and then they can adjust the medications there. Nephrology, you need blood work, creatinine level, electrolytes. You want to see patients for this there. Some sort of dermatology is there too, psychiatry is there too. Obviously, sometimes you have to go to doctor in person too, but that is where the specialty care platforms are kind of the futures there. So this where building this connected healthcare model is kind of what the world is going towards. Now, if we talk about Pakistan, far away, literally far away, because first thing, you need to have a technology, you need to have infrastructure built in order to build this whole ecosystem there. Then you need to have training and then the adaptation of the physician. There got to be reimbursement, and then and all of this cannot happen if there's no legislation to do this there. I'll share some of the proof of concept, and I'll kind of share the story how with this concept we launched project in Pakistan, and I'll share the journey with what were like challenges we were facing, especially initially. And then as we are progressing, there's still a lot of challenges there. And then I'll share what conclusions or what are the recommendations I have come to, our team has come to realize that. What we did is we kind of, to build this whole infrastructure, we decided to have 3 verticals. One was our electronic healthcare record system, what I call technology, which will have everything, what patients would need, what our doctors would need, what our hospitals would need, what the insurance companies would need, built one platform where you can then integrate with other platforms also in that space there. So that's what we built that platform first. We also built a marketplace platform, which we launched, I said, in Shifa for You, and then we brought this into the US with the name of Cura for You in the US, where the idea was that you link, once you have technology, now with that technology, you link all the other services. You link labs, radiology, pharmacy. You give this technology platform access to the local doctors who are in the office so they can open their schedule for appointments. You give this access to the same platform to doctors who want to see patients online. Again, remember, that's not just a video part, because you have to document. You want a patient's information, you want to document, you want to prescribe patients something there. So everything got to be on that one platform, where after you have seen patient, now if the patient needs labs, patient don't have to go somewhere else. It's right there. If you have prescribed medication, patient does not have to go somewhere. He can find a local pharmacy or a pharmacy which can deliver medication at the doorsteps there. So this was kind of what we envisioned to it. And of course, the third most important part was the physician there, especially those physicians who are innovative, young, understand that this is something, and those physicians join us as a leadership for their own respective specialty. And that's how we kind of started journey there. So I compared this with building, because we are building an entire online healthcare ecosystem. When you think about building an actual healthcare system like a hospital, these are the different steps are like you build a building first, takes years to build a building. Then the hospitals, they install all the equipments like lab, radiology, the medical procedure equipment. Then once building is completed, then the hiring process starts. Obviously, a lot of things are going side by side. Physicians and staff onboarding happens. Their protocols become like, okay, the departments of cardiology, nephrology, whatever, all the services, protocols are written. If it's cash-based in Pakistan, most of them are cash-based, but then there are also insurance contracts too. The rates are set. And then they go live and they start patient referral and revenue generation there too. The approach what we took was build it, and keeping in mind that it will be a global online healthcare ecosystem, because every healthcare system has its own challenges. As I mentioned, that having worked in different parts of the world, I got kind of these exposure. Every healthcare system has unique issues there. But beauty of a technology is that you can customize that technology platform in a way that can adapt to that healthcare system there. And that's where the way we were able to expand same product which we built for Pakistan market, we upgraded it, brought to US. We changed the integrations and launch it in Australia, launch in Nigeria. Now we're launching now in Caribbean market, that smart clinic, helping physicians to adapt to their workflow there. And then second step, I built that marketplace in which will be like, rather than installation of ancillary services, you build a marketplace where you connect all the ancillary services. You bring physicians on board who want to see patients online or want to see patients, in the local community there. You start the services, and that's how the pathway which we took there. So when it came to Pakistan, that was the first thing that we did was obviously we built our own EMR system. And the first vision I had was to how can we start second opinion services from Pakistan, from physician in US and UK to patients in Pakistan there. And one of the big challenge was when physicians who were seeing patients here, they said, okay, if my patients now need a medication or labs or something, where to send that? That is where Shifa for You. We built that platform. We integrated our services with labs. We negotiated rates, discount rates, RAVs, radiology, expanded in multiple cities there, and then online pharmacy as well as home care services. We built our customized EMR system and started going to the hospital and physicians to see if they would like to use that and then help their patients to do this. And then the model, what we set for physician services was like, okay, so 4 different approaches there. You could see patients in office, very simple, use the system, just digitize, pretty much standard, like what's being done in the US and some of the places in Pakistan now are using it. Second is that you have on-site clinics where patients who are not tech savvy, they come to clinic, they are seen by a nurse, doctors is remote. Utilization of the same technology for the inpatient ICU, tele-ICU, tele-ER specialists there, obviously played a big role in COVID. And then direct to patients, on the cell phone, all the things there, there's tech savvy there. And the last but not least is the same technology for training and simulation, the courses, simulation courses. What exposure we get in the US and the UK, how can, discuss that with the physicians in Pakistan for there. We actually opened teleclinics, one in Lahore and one in Rawalpindi, start the service there, and planned kind of how can we build this model. I know we gave a free EMR system to the physicians who want to do a volunteer, but also like these were the patients, the paid consultations were there. And utilizing that network, this was the vision, how can we expand this into across the Pakistan, other cities also there. I'll share some of the things what we did became successful, some of them did not. And those are the things which I'm going to discuss more detail, and those are the challenges which we identified. You only know when you start and then say, okay, these are the challenges in real, and then you continue to solve those problems there. That's kind of that's what I think the beauty of innovation and this there that you, and so a couple of challenges. When we reach out to physicians and hospitals to offer our EMR system, electronic health record system there, a big resistance was seen there. One big issue was there were too busy physicians, had no time to write down that. Even they have a scribe or something, they said that will not. Second, the reality is the text purposes was there because there was so much fear that what if those text people, there's an audit and they say, okay, how many patients you're seeing? And then there can be ramification for that. And for text purpose there today, obviously that was the purpose. And this is exactly is happening in the other industry now. Obviously, the government of Pakistan is trying to implement, the online payment portals, and they can use swipe card and stuff like that for the businesses there. So definitely, this will eventually change. Second biggest part for Shifa for you online services, patients. Pakistan does not have a very robust online payment system yet. Like we use credit cards for everything, e-commerce there. We don't have PayPal yet. We have said that EasyPesa, and also we did get integrations on the back end. It took like 6 months to do integrations so with for the payment gateway, which in the US only takes a couple of days. So there was a lot of challenges for the online payments, and then there's still lack of trust. What model is working in Pakistan? Cash on delivery. So patients still order services online, see a disc rates, order it, and there the service provider goes, they collect the payment. But then that they collect the payment, then it's just harder to track that. And then believe it or not, one of the big challenges that also some of the ethics issues where we have partners who kind of working with our labs or radiology, and next day they get a call or they're told by the same service provider who we refer a patient, telling them that they can get a better discount if they can have a direct, call them directly rather next time there. So those were the challenges. What we saw was actually practical challenges, and those challenges are very damaging to innovation. There's no doubt about that. And then there were system barriers. System barriers like there's no telemedicine policy, and no regulations. There's no even. We went to departments and then met a lot of high-end officials, but then there's obviously no. That's where now the government has taken initiatives to draft the policy there. And then there are definitely the training gaps. We wanted to utilize this whole telemedicine, the EMR system, to the university hospitals. I met so many officials from the different university hospitals. They are offered free of service to use our systems to train the residents, because one of the big challenges we know, our medical students, they do not have an idea of the electronic health record system. Most of them do not. When they come to the US now, even the clinical skill examination, when it was there, they were writing it there, or when they start programs in the UK and US, they have no idea about the electronic health record system. And so obviously there are some of the innovation gaps out there. And so those, keeping that in mind, we obviously had drafted this legislation. Now COVID came, and one thing which we know that how this 2020, everything changed, telemedicine, online cares, things happen. Since we were actually already doing this project in Pakistan for labs, radiology, doctors, and everything there, literally this was where we saw so much value. We started offering free online consultation, and we actually brought a lot of other, the service provider, like the oxygen cylinders, oximeters, and set up online consultation call center. I big tribute to a lot of volunteer physicians, over 100 volunteer physicians join us to run that call center. And we also were creating the medical database. And then patients, anyone who's like having symptoms, call us, get a consultation, see a doctor online, get treatment at your doorsteps. If they need a PCR at their home, oxygen cylinders needed there because hospitals were full there. Obviously, there were a lot of challenges that were there, because then as COVID progressed, labs stopped going to home because their own workers got COVID there. Obviously, this was the big challenge what we saw there. But at least we did so much patient education. We have like around close to like a reach of around 1 million people watch the Shifa for You public post on the social media post every month, and then a lot of education that what needs to be done there. So this was what the impact we had. And of course, there's now, I'm glad to see there's so many other good startups, like Manam is a big name, and there's all about like finding a doctor, and they're now doing this part, exactly what the following there. Because the challenge in all those things there, especially when we opened those second opinion service doctors, American Teleclinic, that did not become as successful as we thought initially, because there was time zone difference, and then patients did not want to pay high fee, $150 to $200 for consultation is very standard price here. But certainly the volunteer physicians, those were are still going on. Anyone who wants to volunteer, we give our free clinic. We actually built up during COVID, build a portal for Kemkana to you see those physicians, they can see patients, also provide in the there. So I know time is running short, so I'm just quickly learning from the experiences so far, but that Shifa for you actually help us to build some product, which we then brought to US, and definitely the market the US was right at their time there. I truly believe that Pakistan market will eventually be there, but I think it's the model we wanted to bring in Pakistan. There has to be a few steps which I've shared with the government of Pakistan, and I think those are the not talking about those texts. So I think those are the steps there which I have kind of drafted and shared with the federal minister, the Faisal Sultan, also there. But this needs to be, we have to have EMR implementation with at the institution level, training institution level. Unless we train our medical students and graduating physicians, when they graduate, the utilization is not possible. And until you have electronic healthcare record system there, next steps become very, very difficult there. So the first step got to be mandate the university programs there. Second, the Sehat card program, what they're doing is make those hospitals to utilize that electronic system, at least scan the documents and send that data, so you actually can, fix a lot of some of those unethical problems of corruption, where overcharging was happening. Second step is expand this EMR telemedicine program to government hospital and private sector full scale. A lot of challenges are happening there. I know I talked to them with how they did the Shobha Khanam EMR. They tried to do this in the government hospital. It did not work much. We need a lot of training resources for that. Step 3, obviously, digitization of the ancillary services. Eventually that happen, and then you can have integration and structured analytics. I have heard this word so many times. What actually happened when you talk digital health innovation, most of people start talking from AI, artificial intelligence. And I say, for God's sake, AI will be the last step. You can never have AI unless you have structured data. You cannot have a structured data unless you have step 1 there. So with that in mind there, those are the steps we recommended, and it's recommended that the government need to set up a standard for the EMR and telemedicine systems. They need to mandate this digital healthcare policy at the institution level, training institution level. They need to promote innovation culture. We're very happy to get with the medical students who want to rotate with us to get the exposure to telemedicine, the healthcare system in the US as well as in Pakistan. In fact, in the US, we now have partnered with the University of North Florida. Their students are now rotating with us, doing this learning international healthcare and the US digital healthcare system. So definitely would like to kind of partner with some of the university hospitals who wants to kind of collaborate with us on that. And then certainly digitization of Sehat card will happen, and how in the until this financial incentives or tax breaks happen there. Those are the kind of steps there. So I'll stop here for question and answer. Thank you so much for your patience.
Thank you, Waqas. That was a good overall view of what's happening in tele in United States and in Pakistan. I think we have lots of questions. We'll take them one by one, but at this point, I'll see if Shahid, Danish, or Uzair have any question for Waqas. Otherwise, we'll start taking questions from the people who are logged in. Uzair or Danish? Okay.
Thank you, Babar, and thank you, Waqas. It's a very comprehensive overview. And because I'm more in touch with Pakistan, so I think it's actually a very true picture and very logical and pragmatic analysis. You pointed out many of the issues, and I think that's a good learning experience to all of the physician entrepreneur or the healthcare entrepreneur, that before miring any terrain or the market, they should consider these aspects, and it is a gradual systematic process from the training, from the application. But just a comment that it will be very appropriate at this point in time that you should involve the Pakistan Medical Commission, who are looking after the undergrad and postgrad training as well for the medical institution, and College of Physician and Surgeon, to incorporate the medical record and to the new graduates. So that's just a brief comment. Thank you very much. Pleasure talking.
Thank you, Zaid. Danish, any comment from you?
Wonderful talk, Waqas. I know you have done such a hard work and you have had such a big struggle. So it's so great to see where you have been, where you have reached. And we're both Kemkolians, so that makes me even more proud. And wonderful work. I've always been big more on education side, and your work is more on the clinical side. But I think I have done some clinics in Pakistan, as you know, and I used to do them. But my focus was always that people from the Pakistani diaspora, one of the challenge we have is that even if we provide patient care, we cannot have a continuity of care, and we cannot have after treatment handling or issues or things like that. And I think you worked on it a little bit, creating a model where there's a handoff, or we are work more as a second opinion kind of a way, or like some clinics that are run where there are nurse practitioners who are leading the tasks for more day-to-day activity follow-ups, and we provide only second opinion. Another issue I felt is that the revenue in Pakistan from these activities can never match the revenue in US. So I can do same 1 day of clinic here and earn 4 or 5 times more than what I could make in Pakistan. And so that's why it was always hard to figure out what how to incentivize these kind of work for Pakistani diaspora. Thank you.
Thank you.
Waqas, if you like to comment in reference to that, then
yes,
we'll take.
Thank you. So thanks, Dr. Rozair, for your question about the Pakistan medical. So our team already met. This is where and you probably are aware of like how we have on the back end, we've been meeting with a lot of the government officials as well. And so they've been met with the chairman of the new chairman of the Pakistan medical, the new associate consul. And I think that's where we were told that the first thing is the government is making a policy, and then once the policy is there, then the implementation will happen. So I'm so glad now eventually the policy is in process, and those comments which I've shared are going to be part of that policy. And then if implementation will happen eventually there. Dr. Danishwati, thank you. Yes, thank you for kind words. I absolutely, I remember we talked initially, and this is exactly what when we set up even the second opinion services, we actually open teleclinics at a very high end places too, to see if we can attract the patients who are the problems is those patients who the continuation of care. The big challenge I think is there still that mindset before the COVID was mindset to see a doctor in person. That's where your model, when you were going there and seeing them, and then you wanted just to have a follow, was kind of that continuation of care model did work. But I guess what COVID did change people perspective that okay, the online doctor is kind of the way to there. What I don't think which actually worked was just utilization of physicians who are in the US, and if they're looking to kind of do telemedicine in Pakistan, a lot of physicians who actually, once we did this, was reached to me, they want to start their initiative there. So I told them the challenges were don't expect them to pay the same amount what you basically, because they only pay like 3,000 to maybe 4,000. And a lot of time the question comes, those physicians who actually move back to Pakistan, who were US trained, and they're charging 3,000 to 5,000 rupees there. How are you're going to compete with them unless you're super specialist like yourself, in the movement disorders, and you can obviously charge a little higher. But when it comes to kind of make it a financial viable model, I think you need a volume. That's where the The biggest, I think the moving forward probably will be if the Sehat card is coming and if the private insurance, people who have private insurance and corporates, collaboration with them. This is exactly what we're doing in the US now. The US side also, start with direct to patients. The cash-based volume, people who don't have insurance, big problem, they don't find. But that volume always remains a little lower. But you would have that system in process, then you actually collaborate with the insurance companies and payers and their subscription plans. And I'll be happy to share more into like how we are doing in, like we're doing in the US, like NeuroX, like online neurologist care portal. We started with direct to patients. We then contracted with insurance companies and say, okay, let's say you have 100,000 patients. We can be your preferred providers and then do a subscription plan. So I think moving forward, once Sehat card becomes implemented, having a contract with becoming on that panel where you are actually getting a subscription model where the Sehat card is essentially paying a small fee per patient who you are going to cover, regardless they see you or not. There's like a premium that will put a good revenue stream baseline. But once the patient sees, then even you charge them like 2,000 or 3,000 rupees, that becomes a very viable model.
Thank you. Thank you.
Quick follow-up question, Babar.
Yeah,
Sorry.
yes.
So Waqas, one question I've always thought was, what is the potential of a model where the Pakistani diaspora subspecialists become a consultant to Pakistani physicians, not patient? So a physician can summarize everything, put it in there, we review the case based on information provided, and give a second opinion, which is limited to what is being given to us, and 5 minute, 10 minute, and charge a little bit, much.
We tried our best to offer even free service. I think that's where, unless that change happens from the top, for example, I'll give you an example of the hospitals, the Mayo Hospital. When this COVID came, we actually said, because we had spent so much time and like those challenges were there, the adaptation, and I know APPNA also was doing telemedicine, and so how they were writing a small summary and then physician will log in. If you want to make it as a volunteer, it will work sometime, but then if you want to make it like a viable service there, question who will pay for that. Unless the institute, the hospitals, they pay you. We talked to some of the private hospitals too, and there honestly there was not much interest when it comes to that fund, because the reality is in Pakistan, which is kind of a harsh reality, but it is that most of the things are taken care of by pharmaceutical companies. So unless they tell, okay, the pharmaceutical, because for everything they know that they have a pharmaceutical company, they will set up a room, they will set up, the equipment and all those things there. So we also thought of that will that be something where if the hospital something they can actually engage a pharmaceutical company to help make this a process, kind of a win-win situation. Because on this side, physician side, many physicians who want to do a volunteer, they were wanting to do it. But then think from that perspective, if everyone is doing a full-time job and the time zone difference there, we had the cases where we schedule appointments for volunteer physicians there, and the physician here did not show up, or they had some emergency because they were like, it's too busy, one weekend a month or something. They're like this. So when you're doing for volunteer, getting a quality care becomes very difficult, and that was become a challenge for us, because it was not something which we could promote with quality there. So that's why what we learned is that the biggest need is to connect local patients with the local physicians first, so they actually start getting to it, because then this become a part of the system. And then they think, okay, if we need a service or something, then they can promote there, because I think otherwise local physicians think that, okay, it's, I mean, pardon my words, but it becomes kind of an issue of ego also sometimes.
So Waqas, thank you for those comments. So there are a few questions we should take. Otherwise, so some question from, I don't need to name those people, but that's okay. They're putting their name there. Anayatullah Mehman. He liked the presentation. The question is, there are some potential legal issues such as malpractice maybe, and are there any global guidelines for telehealth or online medical services? So somebody was asking earlier in the same question, are there cross state regulation in United States, but in this case, global guidelines, or is there anything like that?
So thank you. That's so. I mean, the way we work, we have a healthcare insurance policy which covers the global coverage, but there are obviously guidelines. Obviously, in the U.S. guidelines is the physicians needs to have a license of that particular state where they are seeing the patients there. And when it comes to outside the U.S., if you are seeing a patient directly, you ideally need to have a license in that state, because you can pick, for example, if I want to see a patient in Pakistan, I need to have a PMDC license, ideally, as saying, because right now there's no such guidelines. You maybe get in trouble if you don't have a license in there. But those lot of physicians, we have our license expired, or we are consultant. There you can have a second opinion services, because then you are actually, if you have what we did is we actually have a local physician who was with the patient, or even online consultation, or we have so legally you make it the patient is in care of that local physician who have active license, and you bring expert physician just to give a second opinion services, who just gives recommendation, does not order anything. Local physician, if they agree, they on behalf of the advice or the consultant, they kind of there. So that's the kind of legal loophole which we utilize there for second opinion services there. And same is true for the US. If like you are giving US second opinion service physician to physicians, that's completely that's right now it's pretty legal. Dr. Rosaire, I think has.
So I think I'm reading some question. There was a extensive comment by Dr. Abdul Rashid, which basically liked the presentation, but there are issues which obviously we cannot encounter in this talk, such as a lack of reporting system, lack of patient safety culture, no data on antimicrobials, and lack of clinical pharmacists in tertiary hospitals. Yeah, those are all real, but obviously in this little time, Waqas cannot answer all of these, but those are real issues. But I would see if anybody have any burning question, please raise your hand. I'll take the question, or then we'll conclude.
So Dr. Rao, that question, I think where the reporting, that's exactly what I have suggested, that you need to have an electronic healthcare record system, which can actually have all the data there for the physician. Because when we were even like Dr. Danish, but you give a second opinion services, unless you have a patient's data in front of you, the history, lab, radiology, giving any opinion, it becomes very difficult there. We have done actually in the US now taken our company's operations into nursing homes, exactly the same model. What we challenges was there, the data is paper charts and all those things there. So our medical assistant or staff or nurse, they put all the data in the EMR system. And when they are ready for a rounding, as a physician, you are actually ready to have all information in one system. So that's where the need is, to have one good system to be there.
But thank you. I'll take this last. This may be a comment by somebody anonymous. Studies show that there is a poor outcome as compared to older system, except for data collections. So some anonymous paper saying like there is some study which shows like using these EMR systems, outcome may not improve, it's just the data collection. I don't know which study. If you will be kind enough to throw that study in there in the reference, we'll check it out. But it's possible, yes, some outcomes may not be better with that, which is possible. But Waqas, do you have any comment on that?
I'm sorry, Dr.
The question, basically they said using EMR, in some study, they're poor outcome as compared to older system, except for data collections.
No, I guess I think it's on one picture is unfortunate reality is that the EMR in the US became more focused into revenue cycle, like the insurance companies and all those things, because that was
okay.
Right. The good spirit of EMR is to build something what clinical information as a physician needs. I mean, so that's where I think we decided to build our own EMR system to which was focused on actual patient information, what a physician would need, rather than what the insurance companies would need, because that becomes there. Dr. Barbara, I think there's one question.
Yeah, I think Sarvat, he's
Yes.
one of our regular panelists and part of our team.
Yes.
He has a question. Go ahead, Sarvat.
Assalamu alaikum. First of all, congratulations. That is fantastic. And I really believe that if you were to make your system beneficial to underserved population, you could win a Nobel Prize, honestly, in the world. Having said that, I have been thinking for a very long time to start a mobile radiology service where CT scan, ultrasound, and X-rays will go to the patients and to those hospitals that cannot afford those machinery, and provide them like in online teleradiology services, and take the machines over to the patients who can afford it but cannot come to the hospital or are too sick to be moved. That's all my comment. Thank you.
Thank you, Sarvat. Thank you.
Thanks.
I think that takes us exactly to on-time conclusion of this session. If anybody have more questions, please shoot it to us in email to APPNA Merit or Waleed or me or Danish. Otherwise, we'll see you again next week. Danish, any comment in closing or
just
just a minute, just a few seconds. Waqas, there is a change with the Pakistan Medical Commission. If your license is expired for Pakistan, now you can get it renewed online within few days only. So that is the service available. So I think you can bypass that legal implication. So I had just spoken to the top man, and that's in place now. This is just
so much.
Thank you
so much.
Thank you.
And
Waqas,
last comments on Dr. Sarvat Sen. Thank you so much for that kind comments there. And it's very, I agree with that service which you want to do that's exactly very much needed for the mobile imaging. I just want to share a screen where we launched this project Corona X. We was doing a lot of free stuff, and what we did is we built our portal for physicians who wants to see patients voluntarily. We actually had a lot of Indian physicians they're seeing patients utilizing this portal in India. And then we have a similar service with physicians who are American, Pakistani, or British Pakistani, and they want to utilize this platform to see patients in Pakistan free of cost. It's a kind of it's a free service. We give them free access so they can see patients are utilizing that there as well there. So just want to share, there are a lot of resources which we are providing for the patients who are don't have much resources.
Thank you, Waqas. So I'm sure many of us will be contacting you to see how do they get to use these free services. But in the meanwhile, anybody have question for Waqas or Danish or APPNA Merit or Uzair or Sarvat or any of us, please shoot an email. Otherwise, we'll see you guys Sunday. Just to remind everybody, on December 22nd this year, we will have a Merit special one-day conference in RMU in Pindi. We welcome all of you and would like you to have you join if you could, online or in person. Some of you were requesting to present there. Waqas will be one of them. Obviously, Uzair will be too. But it's at December 22nd. Please just save the date, and me and Danish will be sending some agenda and some more information about it in next week or so. Thank you, everyone.
Thank you, everyone, so much.
Thank you so much.
Thank you.
Thank you.